So I will be uploading the entire video onto YouTube as well, and all your contact information will be there. It's all going to be good. Okay, so if you're ready, I'm going to hit record separately on the audio in 3, 2, 1. Hi, everyone. Welcome to Sandy K Nutrition, Health and Lifestyle Queen. Today with me, I have a special guest, and her name is Kristin Mallon, and she is a highly accomplished and passionate board-certified nurse midwife with over 20 years of experience in women's health. Her expertise in menopause and feminine longevity has made her a respected and sought-after expert in her field, and she is dedicated to providing the highest level of care to her patients, and her practice name is FemGevity. And I love the name because she doesn't just look at getting rid of symptoms. She's looking at really our health span as women, because things drastically change around menopause for us. And we're going to cover all of that. But the one thing that we are going to talk about mainly is we're going to discuss non-hormonal options to help women through menopause. You know, I've gotten a little bit of slack here because everyone sort of thinks I'm like only about hormones. And hey, don't get me wrong, hormones are beautiful. I love hormones and optimizing hormones for women at menopause. But I respect that there's women who don't want to go that route. So I have the lovely and talented Kristin here to talk to us all about these other options. So with that, welcome, Kristin. Thank you so much for coming.
Thank you so much for having me. I'm so excited to be here. And I mentioned before we started recording, I think that you're asking the right question. So I'm really excited to have this conversation.
Yeah, I am too. I think it's going to be a really good talk. And any of you ladies out there who just say hormones are not for me for whatever your reasons are, this is the show for you. So we have to first, I have to ask you, you've got a long history of working with women. So tell all of us your story. How did you settle on FemGevity?
Yeah, it's been a long journey to get here, but I originally became a midwife really early on in my career, and I started working in private practice in Brooklyn and working. I really wanted to kind of work with women throughout their whole lifespan. So I kind of wanted to work with women like right around college, 18, like when they were coming into adulthood, through having children and through menopause. And I've just been really fortunate to be able to kind of be placed in different positions and then ultimately start my own private practice in 2010 to work with women in that way. And then, you know, in the beginning, a lot of women that I worked with were younger and were having babies in their 20s, 30s, and 40s. But since I've been working for 20 years, those women have gotten older and they've moved into their 50s and 60s and some into their 70s. And so their needs have changed. And so that has also made the needs of how I practice and the research that I get into, and, you know, what has been the most important thing for me to kind of bring to the patients change. And then ultimately, I kind of, you know, and I think this happens to a lot of OBGYNs because birth work is very difficult. It was just a very natural transition. Now, more and more of my patients were moving into the 40 plus range. And so it was a natural transition for me to focus on feminine longevity and women's longevity, which includes menopause. I mean, I think a lot of women really start to think about long-term longevity when reproductive longevity is kind of coming to the end of its time.
Oh, I agree. There's just so many changes that take place, right?
Yeah.
And, you know, we hear, you know, if you were to just watch and read the news about women once they hit menopause, it can be pretty daunting, right?
Yeah, I think that it's kind of been this big bad boogeyman for a long
Yeah.
time. And I think a lot of that comes from the lack of knowledge and information and discussion and openness. I think similarly to how we kind of thought about miscarriage and fertility. And I think we've done a pretty good job. You know, I like to stay optimistic and positive and see like the big strides that we have ways to come too. So I don't want to take away from that either, but we've come a long way in talking about miscarriage, and we've come a long way in talking about fertility and the infertility journey that women go on. And I think menopause is up next, and let's go there next. Let's go menopause.
Yeah. Yeah. Let's go. Because the other thing too, like you're saying, as a nurse midwife, you know, I feel like we've definitely come a long way with women post childbirth, right?
Yeah.
Like, you know, I felt like I was not being taken care of at all. It was all about the baby. And here I was with my own issues. And, you know, I think I can't go back, can't go backwards, but I know I had a lot of issues after I had my babies. And it was after my second one that I had the issues with thyroid, undiagnosed. And then many years later, welcome thyroid cancer, right? So I think women's health, I do believe we are complex beings. And I'm not saying men don't have their issue too. They also have their issues, but I think we're way more complex, Kristin. I really do.
Yeah, definitely. And that's the whole point of FemGevity, is that when I looked at the field of longevity medicine, you know, you have your Peter Attia and Dr. David Sinclair and Andrew Huberman and, you know, Tim Ferriss and all of these men talking about male dominated studies and how it affects men and how fasting affects testosterone and how it affects their fat burning capabilities. And no one is talking about women, and no one's really talking about like, well, how is longevity different for women? And then when I started looking into this and kind of really like digging my teeth into menopause, you know, maybe like a decade or so ago, I was like, wow, like the way a woman goes through menopause significantly affects her longevity in the terms of the 4 horsemen of disease, which is like cardiovascular disease, the number 1 killer of women,
Yep.
and metabolic health, bone health, and Alzheimer's and dementia.
Yes. I'm so glad that you mentioned that, because we, and people say this all the time in our industry, we are not little men. We are not little men. And I'm going to sing that from the rooftop, because we're not. And I love Peter Attia, and I love Huberman, and I love Ben Greenfield. I actually really do. But they do primarily look at male studies. And they're,
Yeah, and they usually interview men, about male things. And then I think even when they talk to women, a lot of times it's still about very generic things. You know, it'll be about sleep or it'll be about meditation. And, you know, it's not always so feminine specific. It's
yes.
hard to find good information from their platforms about
Yeah.
women specific issues.
So I do want to clarify this, because a lot of people who are listening are from all over the world. I have listeners globally. So what exactly is a nurse midwife?
Yeah, that's a very good question. And it's kind of confusing. In the United States, we have they call it levels of practitioners. You kind of have the base level, or entry level, maybe is a better word to describe it, although I don't think it really has a name. And that includes your nurses and your physician assistants. And these are people who usually do 4 years of schooling. You need 4 years of schooling to be a PA, 4 years of schooling, most cases, to be an RN, although we do have some 2-year degree programs. So that's where that can be confusing too. In order to be an advanced practice nurse or nurse practitioner, you need to then have a nursing degree and then do an additional, typically master's degree. So most nurse practitioners, or now doctorate is becoming pretty common. Like a lot of nurse practitioners are doctorate. So I'm from before the time when doctorate was a common, you know, I graduated in 2006. So I'm, you know, much before the time when doctorate was a thing for nurse practitioners. Of nurse practitioners, there is that's a group of advanced practice nurses. There's something called a certified nurse midwife, which is a different type of nurse practitioner within that group. There's also something called a certified nurse anesthetist. And those are the people that can like do anesthesia, do epidurals, function very similarly to how an anesthesiologist can function. And so I think so I always say certified nurse midwives and certified nurse anesthetists are the most commonly misunderstood group of advanced practice nurse practitioners, because we really function almost exactly like how our physician counterparts function, where most of our other advanced practice nurse practitioners are working alongside and in collaboration with an MD. A lot of states will recognize certified nurse midwives as independent practitioners, meaning that we don't need a collaborating physician. We can have our own business. We can hang our own shingle. And that's not the case with most other nurse practitioners. It's very complicated. It's a complicated question.
Okay, no, but that's good to know, because you have your own practice and you can prescribe and you can do diagnostic testing. You can do all of it there,
Yeah,
correct?
so most certified nurse midwives, like how certified anesthetists are acting as anesthesiologists, most certified nurse midwives can act pretty much as an OBGYN. The only difference, the major difference, is they can't act as primary surgeons on cases. So they can act as assistant surgeons, but they can't act as primary surgeons. Pretty much everything else, so ordering, prescribing narcotics, doing different types of surgical repairs, diagnostic procedures, certified nurse midwives that's within their scope of practice to do.
Okay. Okay, this is good to know, because depending on where you're at, a midwife can mean so many different things.
Yes.
And I want people to realize that you are an expert in this industry.
Yeah, and it's different. And to your point, it's different than a lay midwife. So lay midwives often will just have community training. That's very common in like communities like Amish communities, or, communities that are, much more insular. And there's also something called a certified midwife, and certified midwives are not nurses. So they're not certified nurse midwives, and they don't fall in the nursing jurisdiction or the nursing regulation when it comes to boards, board certification or state certification or state licensing. So that those are CMs versus CNMs. I'm a CNM. And then also there are, I think they're called professional midwives. And so that's a different type of certification board and a certain type of governing board. And those are usually people who do births, but they don't prescribe medication. So they do more home births. They can't practice in hospitals. But people always ask me, oh, you do births at home? And I'm like, no, I work in a hospital just like an OBGYN. I do all of the different types of surgical procedures just like an OBGYN.
Okay, good. Good. I'm glad we clarified that. All right. So let's get into this. What are, and I know I've read a lot and researched a lot on the symptoms of menopause, but what are the main symptoms that women will come to you for?
Yeah, so I think the best way to break that down is perimenopausal symptoms, menopausal symptoms. And by menopause, menopause is defined as one day, but I think colloquially, like in the community, in layman's terms, we think of menopause as kind of like the time when our period ends, the time around when our period ends, that year maybe, and then postmenopausal symptoms. So premenopausal or perimenopausal symptoms are really more usually sleep disturbances, mood changes, insomnia, weight gain, hair loss, anxiety. That's kind of more of the symptoms that come along with perimenopause, which can start usually like anywhere between a few years to like a decade before actual menopause. Menopausal symptoms are more your classic vasomotor symptoms, and these are your hot flashes. These are definitely sleep disturbances is like the number one, one of the number one symptoms after hot flashes, I think, that go along with menopause specifically. Obviously, changes in the menstrual cycle or the cessation of the menstrual cycle completely. Sometimes the return of puberty-like symptoms, so breast tenderness or bloating, gas, acne, things like that happen during menopause. And then a lot of vague neurological things happen during menopause because of the loss of estrogen. And so this is where we, again, get mood changes, mood disorders. We get really unique symptoms like ringing in the ears or tingling on the nose or numbness and tingling in the hands and feet. I think a lot of women can get misdiagnosed as having fibromyalgia during this time, or, malaise.
The joint problems, right?
Yeah. And then the joint problems, I think a lot of times I see that more commonly, although it can be common across perimenopause, menopause, but I see joint pain much more commonly in the postmenopausal time. So this is like you're maybe 1 year out. or you're in the time of like no period, now is when I see more of the joint pain, and I see a lot more of the low libido, and more of the sexual discomfort, sexual pain, urinary symptoms. You know, the genitourinary syndrome of menopause is really kind of more of like a menopausal, postmenopausal time that I see those symptoms. Now that's like totally generic, because you can definitely have joint pain in perimenopause, and you can have, you know, your mood changes in postmenopause, like no mood changes your whole time, and then now you're having mood changes and sleep disturbances postmenopausal. So, but that's kind of the vague overall sense of how the symptoms go.
And there's also a lot of crossover, like you said, right? Like it gets really confusing. I know for me personally, my biggest challenge is because I do not have a thyroid at all. Is it thyroid or is it menopause?
Yeah. And
right,
I think,
right?
yeah. And, you know, we get that question all the time. I actually get that question. We do Instagram lives, and we get that question all the time. And I always tell women that like thyroid is so similar to perimenopause and menopause that the only way to really know the answer to that question is diagnostics. Like you got to get the lab. You got to get the lab data to tell you, is it thyroid or is it perimenopause or menopause?
Yeah, because I mean, even that drop, because I've done a lot of research on estrogen and thyroid function,
Yeah.
right? Like why
Yeah.
do
Yeah.
so many women have thyroid issues around menopause? Because too much estrogen or too little estrogen can affect those receptors. Even in my medications I was reading about and researching, because I live off of medications because I don't have a thyroid at all, right?
Yeah.
So it's so complicated, Kristin. But
Yeah.
I mean, like you said, I'm fortunate in that I have an amazing endocrinologist. He really follows me carefully right now during this time because I'm 53, right? And you know, my last period was in December, and we're recording this in September. So anyway, it's complicated, very complicated. So
yeah, and like, you know, even the thyroid gets, most women will have thyroid disturbances or abnormal thyroid labs in pregnancy, and that's like, to your point too, the same thing happens in pregnancy when you have very high levels of estrogen or estriol.
yeah, it's definitely confusing. So I have to, we have, you know, I know we talked about this. I know you and I are both pretty aligned in that we love hormones to help. So we do need to touch on this. I know this show is supposed to be about non-hormonal options, but we have to touch on, I would love for you to just tell me why hormones are beneficial during well, I started taking progesterone bioidentical in perimenopause. But then, you know, then it came to a point where I needed both. So tell us why are hormones so beneficial?
Yeah, so there's been quite a few studies. So in the US, we have two kind of like just like platinum standard journals. One is the Journal of the American Medical Association, or JAMA. The other one is the New England Journal of Medicine. They have had numerous studies, and you know, there's different quality of studies. So, you know, and even when I was doing the research about the talk that we're going to do today about um, non-hormonal therapies for menopause, you know, a lot of the studies on the non-hormonal treatments, because they don't have big pharma backing them, are with very small sample sizes, which makes the quality of the evidence very low. So when something gets into JAMA, or when something gets into the New England Journal of Medicine, and when it's a systematic data review, it is the highest level of evidence. It is the most, it's better than a prospective study, it's better than a double blind, it's better than any type of study that can be done. And there have been numerous studies that show that estrogen is the most effective treatment for the symptoms of menopause. So when you go through all the hormonal treatments that are pharmacologic or non-pharmacologic, so we're talking about herbs and supplements and soy, and we'll get into all of those, it's just proven time and time and time again that it's just the most effective treatment out there. So that's the first thing. The second thing is that women who take hormone replacement therapy, and we're talking about whether it's, I always call it commercially made or bioidentically made, even though there are bioidenticals that are available commercially. And, we can get into the whole reason about what the differences are between those. Usually the bioidentical that you get from a Walgreens or a CVS, which are the main pharmacies we have here, like the big pharmacies on every single street corner, they're going to have fillers, they're going to have glycols, they're going to have mineral oil in them, they're going to have substrates in them which give them a shelf life of 2 years, versus a bioidentical that you get from a compounding pharmacy isn't going to have any of those fillers. You can control for what fillers are in there. You can get it with an oil that is, like hyaluronic acid, or an oil that's made specifically for you. And you can, and the most bioidenticals, the shelf life on them is 3 to 6 months.
Mm-hmm.
So I'm getting off topic, but so there's many articles about that it's the most effective. There's many articles that there is a significant reduction in cardiovascular disease. Some of these articles will quote a reduction of 30% in atherosclerotic disease and plaque buildup and coronary artery disease. Some of them as much as a 50% reduction. And I think that cardiovascular disease does not get the credit that it is due. It is the #1 killer of women. It's going to kill 1 in 4 women. And it's so underrated, understudied, under-talked about, not monitored closely enough. And that's a huge thing that we do at FemGevity, is we monitor all different types of diagnostic testing for lipids and ApoB and Lp(a), and not just, your cholesterol, HDL, LDL. But that's, time and time again, they've proven that HRT is cardioprotective. Now let's get into bone loss prevention.
Oh, yeah.
The bone loss prevention that comes from hormone replacement is just significant. The same amount of women die from an osteoporotic hip fracture that do from breast cancer every single year once you're over 50. And so I just think that that's another totally large cause of mortality and morbidity that is totally under talked about, understudied, underutilized. And when it comes to HRT, these are things that women need to know, that the benefits are there, and the choice is theirs to take it or not, of course.
Yeah.
It can also decrease your chance of colon cancer. It can also decrease not just from hip fractures, but all bone fractures and bone loss in general, making it so that when you get to the end of your life, you're not, I talked to someone yesterday, I'm a rower, they're a rower, and they were like, oh, my goal in life is to be 90 and able to get into a boat, get into a rowing boat, or be able to put my suitcase in an overhead bin so I can still travel when I'm 90 years old. And estrogen is going to help women be able to do that if they choose it.
Yeah.
There's also there was an article in the New York Times a couple years ago about when that Alzheimer's drug failed. There was this very large trial and the Alzheimer's drug failed. And the New York Times article went through all the different drugs that they've tried for Alzheimer's, except estrogen has been proven to be neuroprotective against cognitive decline. And so I think that that's where the benefits of estrogen really lie. And I think that, we could have a whole podcast about how women were misled about the estrogen breast cancer link. We now know, and if you go on a very good website, it's a very good reference website called Estrogen Matters. There was a book written that basically explains why that WHI study that was published in 2002 that halted the use of hormone replacement therapies, like basically across the world, one study overnight. I mean, that's never been done before in medicine, ever.
Yeah.
If somebody publishes a study that says, okay, the side effects of this medication, I mean, it wasn't even statistically significant. The p-value wasn't even strong enough to be statistically significant. They will look at it, do maybe a double-blind study, maybe do a prospective study. They'll put people into randomized groups. We didn't even have that here. Halted the use of estrogen across the almost the whole world, and they've written a book about how estrogen not only does not increase the chance of breast cancer, but reduces the chance of breast cancer. There's a lot of studies coming out now about women that have had breast cancer that are going through IVF, and their exposure to estrogen through the IVF treatments and the IVF cycles is not increasing their risk of breast cancer, even in ER positive breast cancers, and even in women who have BRCA1 and BRCA2. So I just think that estrogen gets a bad rep, and there's so many benefits. And I really like to look at the benefits of not taking something along with the risks of taking something too. And I think that there's estrogen has a lot, and progesterone and DHEA and pregnenolone. I mean, these are hormones that go, and testosterone. These are hormones that go along with HRT. There's a lot of benefits to taking them.
I'm glad you went through that. You're gonna laugh, Kristin. I actually put out a reel a while ago, and this is just an aside. And my very first line was, estrogen does not cause cancer. Do you know how many people that triggered?
Yeah, I believe that.
I was like, holy shit, pardon me. But I'm like, people, relax. Like, I'm saying, and yes, there are estrogen sensitive cancers, but estrogen in and of itself does not cause cancer. It's what's going on with that estrogen. Where's it going? What's it doing? But that's why there's practitioners like you who help to monitor to make sure that your estrogens are properly being metabolized in your body.
Yeah. And
But
that's
we've had
huge.
estrogen our whole lives, Kristin. Like, come on. Right?
Totally.
Are you telling me that just because you're 15 years old, you're getting your period, now you got to be careful of estrogen?
Right. Or if that was the case, we would see, estrogen is very high in pregnancy. And so we would see women that have multiple children having abnormally high rates of breast cancer, women that have 20 children, 15 children. I mean, I worked with the Orthodox Jewish population and a Muslim population most of my career. I mean, I've been in Brooklyn and New York City. And so that's not what we see. We actually see a decrease in breast cancer rates in women who have that many children. So I think what you're talking about, and you probably know more about this than me because this is more your area in nutrition, but you're talking about the estroblome, and you're talking about beta glucuronidase and how we metabolize these estrogen metabolites. And so is it the estrogen, or is it the estrogen waste products that we're not metabolizing properly because we don't have the proper liver detox and the proper gut microbiome balancing? So, a totally separate.
It is. Yeah,
But
it's a whole other conversation.
If we really look at this, the WHI study from 2002, which was published in JAMA, is the study that halted the use. And this is where everybody's getting estrogen causes cancer from. And if you go and you read that study, you're going to find that it's actually the methoprogestate that is linked to the increase in cancer. And nobody talks about that.
What's that, Kristin? I don't know about that. Tell me.
Yeah. So, I mean, that's just basically the progestin. So that was.
Yes. Isn't that the horse urine?
No, that's Premarin.
No. Okay. Clarify, please. Clarify, because yes, I did hear this.
Yeah. So first of all, that study in 2002, they were using estrogens that we don't use anymore because they were using horse urine estrogen, Premarin. Right. Very few old school doctors still use that. But nobody really uses Premarin anymore. The arm of the study that increased the risk, I was looking to see if I have my Estrogen Matters book here so I could quote it for you, but the arm of the study that has had the increase, and you're talking about, it went from 3 in 1,000 women to 4 in 1,000 women. Okay, so that was the difference in breast cancer rates. And we're not talking about morbidity or mortality from breast cancer. So the long-term follow-up was no different, but it was in the Premarin progestin arm. And actually in the estrogen only arm of the study, there was a decrease in breast cancer.
Yeah.
And so that's something that's like so important about how this study was misconstrued, and why Dr. Avram Blumring, who is a hematologist oncologist, whose wife actually ended up having breast cancer, he wrote a book with Carol Tavers called Estrogen Matters. And anybody who tells you that, Sandy, anyone who tells you you're wrong about estrogen causing breast cancer, I would say, do your research, read Estrogen Matters, and then come back and let's have a conversation, or let's have a debate about it. And I'm happy to have that conversation any day, all day long. I mean, eating French fries I think it's like, I can't remember how many servings of French fries in a year, but it's not a lot. Eating a certain amount of French fries in a year increases your chance of breast cancer more than that study did. Drinking alcohol.
I was just going to say, how about wine? Because Kristin, I have actually, we're totally getting off topic, but I read an article saying alcohol is like the new smoking for menopausal women.
Yeah, well, alcohol intensifies hot flashes like more than it's over 200%.
Yeah.
So if you're experienced, but a lot of women don't want to give up their alcohol in menopause, and then they don't want to take hormones. It's kind of this 6 dozen of one, half a dozen of the other kind of thing.
Yeah. Anyway, okay. You know what? I think it is important to talk about what we mentioned, because I am, and I make no secret of it, I'm a massive advocate of hormone therapy. And I think if you work with somebody who knows what they're doing and you're doing it right, it's a positive experience for anybody, any woman. So why do some women choose not to go the hormone route? Is it because of what we talked about, that big cancer fear
So I
mongering
think
study that's
I would say
faulty?
that just in my experience, I would say that's about 70% of it
Okay.
is that it's misinformation and it's cancer fear. And a lot of women that they don't even have breast cancer themselves. And I have women on the other side of the fence, women that have had breast cancer themselves, are very informed, have very progressive oncologists, because Mount Sinai is doing multiple studies now with women who have had breast cancer on estrogen. And so New York City is kind of like, we're very progressive here.
Yeah.
But so they're on the other side. They're like, I really want to take estrogen. I've read all the studies. I'm in conversations with my oncologist. Can you talk to my oncologist about it? And I'm having those conversations with some women, but then I'm having some conversations with other women where they didn't even have breast cancer themselves. They have dense breasts. They think they can't take estrogen because they have dense breasts, or it's not even estrogen. They think they can't take progesterone or DHEA, which DHEA is available over the counter, progesterone available over the counter, just because they have dense breasts, or because they had an aunt who had breast cancer, or because they're BRCA positive, or their mom was BRCA positive, and they're not even BRCA positive, they're BRCA negative. So there's just a lot of, fear is a very potent drug, and it's a very powerful motivator. And I totally understand, and I empathize, and it's hard to go against something that you've been told and taught. I mean, we've been taught that for 20 years. I mean, that study came out in 2002. I mean, we're coming up on 21 years of this type of indoctrination, not just from clinicians, but also from the public. And then patients will go to their doctors, and their doctors, I mean, when I was in school, so I was in school right around the time that this study came out, I was taught, oh, menopause, estrogen's going to kill people. You can't give that to people.
Yeah.
And menopause is short-lived. Just tell them to suck it up. So basically, I was taught in a midwifery program,
Yeah.
just gaslight women, and there's nothing you can do or nothing you can offer them. And here's a list of herbal supplements that you can, speak to the lay midwives about, and figure out how you want to help women with these supplements, which some can be very effective. So, we can get into that too.
Yeah. I mean, that whole fear thing, because here in Toronto, you have doctors who they're oncologists. They actually put women on drugs to take away all their estrogens after they've had an estrogen positive cancer, right? Like, you must know that better than I do.
Yeah. So like tamoxifen is an anti-estrogen
Right.
medication.
So
Yeah.
they take away everything. So these women who have not only suffered with breast cancer are now suffering with some pretty shitty
Menopausal.
symptoms.
Right. Yeah,
Because,
menopausal symptoms. Yeah,
yeah.
pretty quickly too.
So what you're saying is there are doctors who are much better, well studied, well read, well researched, where they help these women post breast cancer.
Yes. Yeah. So that is we are now starting to see more and more of that in New York City. Yes.
Yeah.
And
Yeah.
I'm not really seeing, and so I always kind of feel like New York City and Los Angeles kind of go hand in hand in terms of medical progressiveness. And I'm not seeing that in LA yet. And I think that's how deeply ingrained this concept that estrogen causes breast cancer is in our society. I think it's probably the deepest misinformation of anything medical that we've ever had ever.
So yeah, because I had an aunt that died of uterine cancer. I don't carry the BRCA gene, but my aunt died of uterine cancer. That's one of the cancers that is considered an estrogenic linked cancer. Linked, not caused, linked, right?
Mhm.
And I also had a breast tumor, same time that I had my thyroid removed. So it was benign, but again, it's to your point about dense breast tissue,
Mhm.
right?
Right.
So you're saying a woman in my scenario would simply say no.
Well, many. And then I think that the other maybe 30% of women that I see have the idea that menopause is a natural
Okay.
course in life. And that, I mean, I would say that that's probably, I think the other 30% of women that don't, I think the most of the women that are very adverse to hormones, it's this fear of cancer. I would say that that's more than 50%, somewhere in 60, 70%. And that's just kind of like my own experience. And then the other 30% is like, they don't, they don't take medication. They don't, whether it's religion, they're Christian Scientists or Seventh-day Adventists or Jehovah's Witness, or they don't believe, they think that menopause is a natural state. And they're like, I just want to go through menopause naturally. And I like to do everything as natural as possible. And these are a lot of times women who don't even take supplements. They like to do things with food, or they work more in that realm. And I think it's very similar. I mean, we see this a lot in medicine, and all different choices of medicine that women can make. Like in birth, for example, we have women who choose birth with epidural and birth without. We have women who choose C-section, and women who choose, to do a natural vaginal delivery. We have women who choose VBACs and women who don't. We have women who put like do not resuscitate on their medical form. So they don't want to be resuscitated. They don't, if they're about to pass on, if something happens, if there's a crisis, they don't want to be resuscitated. We have people who refuse blood transfusions, so I think there's a lot of different beliefs for a plethora, just as many fingerprints as we have in the world. There's probably just as many reasons why women choose not to do hormonal medications. And some women really can't. Some women who have had a history of blood clot may not be a good candidate for estrogen.
Okay.
Some women who might have certain cardiovascular events pre-menopause, certain types of high blood pressures that are estrogen dominant or estrogen related might not be good candidates. Someone who's had a history of pulmonary embolism or any type of significant cardiac events might not be a good candidate for estrogens.
Okay. Thank you for outlining that. I think that's important to outline that. And, I will say I always respect people for their choices. What I always like to do, though, is to not spread false information.
Yes, of course. Yes.
I'm like, listen, it's everybody's choice. Like you said, to go through menopause naturally. If you want to do that, by all means, go for it. I just don't like the false spreading of information and making things more clear for other women so that it's not fear mongering. That's all.
Exactly. Yeah. And we definitely have that with the breast cancer information for sure. We
I
definitely
love that you communicate that so clearly. Okay. So let's get into the non-hormonal part of the discussion. And I think we should split it off with, on one side, pharmaceuticals, because I know that there was a big drug released recently. And then on the other side, natural options. So
Yes.
let's do the pharmaceuticals, because I know nothing. I've only heard of the one drug, Vizoa. What is it called? Vizoa?
Well, I
Vinoa?
think people say it
What is it?
differently, but I think it's Viuza or Vioza.
Okay.
Yeah, it's
Yeah,
not
I
really
don't
like
know
in
even
common
how.
speech, so we're not saying it a lot. So I think we don't always. I've heard different newscasts and people pronounce it differently. So
So how are you pronouncing it, Kristen?
yeah, Vioza, Viuza.
Vioza. So what is Vioza and what does it do?
Yeah, so Vioza is a neurokine 3 antagonist. So it blocks this neurokine in the brain, which basically triggers the brain to have a hot flash.
Mm,
Yeah,
wow.
so yeah, it's basically a receptor antagonist.
Okay. So it's for
And
hot flashes.
yeah, and
It
so
doesn't, nothing else. That's it.
yeah, that's the main mechanism of action. It regulates the secretion of gonadotropin release, and so it reduces hot flashes. I think that's really what they've the FDA has approved it for is for the treatment of vasomotor symptoms. So whether that then has a sequelae into, okay, well, now a woman's having less vasomotor symptoms, does that mean that she's sleeping better? Does that mean that she's, not as depressed, as anxious? It probably, I would assume, because I think a lot of times hot flashes can go along with palpitations. Palpitations is another common symptom of menopause. To me, that would make sense. That's not clearly defined as a benefit of the drug yet, but I could see how that could potentially be coming for someone who uses this medication. I don't have anyone on this medication. I don't have any colleagues who have anyone on this medication. A lot of women that I've talked to about it, because I've had conversations about using this medication, they are like, well, it's too new. I don't want it yet. What else you got? Kind of thing. So that's been my very limited experience with this medication. So I couldn't really speak on like what patients are saying, how it's working. None of my colleagues even are prescribing it yet.
Yeah, it's interesting because that's the drug that came out shortly after the article about women have been misled about menopause, right?
Yeah.
Isn't that
Timing
interesting?
is interesting.
It is interesting because that was a massive article in New York Times, right?
Yeah.
That was
Yeah.
huge. So anybody who hasn't read it, maybe if I remember, I'll link it in the show notes, because this drug came out shortly after. And do you know if there's any side effects?
Oh, I'm sure there's side effects. So I know that like on the drug manufacturing, so I don't have tons of experience with this drug because I don't use it yet. On the manufacturing label, we're supposed to check liver enzymes. If we prescribe it, we're supposed to, like, contraindications would be cirrhosis of the liver. So that to me I would assume that it's going to have GI side effects, because that means it's going to be harsh on the liver, and then anything that's harsh on the liver would then transfer into the gastrointestinal system.
Oh, okay. All right, that's good to know. And then, of course, there's always depletions of nutrients in a lot of the drugs that are pharmaceuticals end up depleting nutrients elsewhere in the body, right?
Yeah, and I think
So,
to kind of jump over into the non-pharma side of treating menopause naturally, the number one thing I always recommend women do first is liver detox. So then this is like the total opposite of that recommendation. Usually detoxifying the liver, like I said, helps the liver to then process those estrogen and other hormonal metabolites easier. So then, to hopefully reduce the severity of symptoms that a woman's experiencing if she's choosing to go through menopause without any HRT or any hormone replacement. So,
okay. So how do you do that? Because I'm always like, please don't go to your natural health store and just buy a liver detox box off the shelf. Please don't do that. How do you just quickly help women to do a liver detox?
well, if they're open to it, fasting,
Ah,
usually in combination with lemon and milk thistle, is the best, but not every woman is open to the concept of fasting. It's hard. And sometimes it takes a little bit to kind of build up to the ability to fast for long periods of time. Usually to say that a fast, I think, is a real fast, I usually say it needs to be about 36 hours. Otherwise, it's just time restricted eating, or it's intermittent fasting, which I think is a different thing than fasting, and you get different effects. I will sometimes recommend Prolon. So I don't know if you've ever used that company.
I've done Prolon a couple
Yeah,
of
so
times.
I will recommend Prolon for women who feel like they need a little bit extra support. But that is very, very helpful for liver detox. I mean, we've done before and after labs on women. I mean, it's profound. I mean, even hemoglobin A1C, fasting insulin, liver enzymes, just within a week can really significantly change with a 5-day fast. So if a woman doesn't want to go on a 5-day fast, then it's kind of then again meeting her where she's at and saying, okay, well, what are you capable of? Are you capable of doing time restricted eating? Are you capable of doing a clean diet? Are you capable of doing a juice fast? Like, what are we capable of doing here? And then trying to get the diet as clean as possible for as long as possible. And then maybe adding in dandelion root or with the milk thistle and the lemon to get the liver to be as clean as possible. Sometimes we do celery juice. I don't know, I've had kind of different, I don't know what you've experienced with that, if you've had good results.
For me, I'm always about, like you said, whole real foods, of course. Fasting, I think, can be tricky for some women, and it depends on what's that foundation, right? Like,
Mhm.
how strong are her minerals? How healthy is she in order to do the 5-day fast? Because sometimes women are going into, and honestly, Kristin, I'm sure you would agree with this, anyone going through menopause, it's always going to be easier if you go in and do the work in advance.
Yes, of course. Yeah.
Right?
Yeah.
Like if you're like, drinking a bottle of wine every night, eating whatever packaged foods that you can find in your freezer every night, or the majority of your diet, you don't move your body, you don't do anything that is good for mindfulness or meditation, well, you're going to have a harder experience. And some of these things are not going to work as well for you.
Yeah. And especially like when someone says they don't want to use hormones, then that's when I try to kind of get them to come around to like, okay, like this is, it's kind of like, if you want to go the natural route in life, I mean, think about it. Like, we use electricity, we have indoor plumbing, we drive cars. Like, the natural life would be to live outside and to not have indoor plumbing or electricity and to walk everywhere. So, sometimes the non-hormonal, non-pharmacological route is, it just requires a lot more work and a lot more that goes into it, which is a totally perfectly valid and wonderful and beautiful choice. And we're here for it. We're here to support you in it and tell you what the steps need to be and hold your hand through the whole thing. We're happy to do that.
Okay, so really, in terms of pharmaceuticals, just to finish off that conversation.
Yeah, that's
That's like the one big
yeah,
pharmaceutical
that nobody's using that I
that
know of.
nobody's using.
Yet. Yeah, I think it's just too new for patients to feel comfortable, at least for me. I think that it's kind of been used readily in the clinical trials. I think that even the people who have been on it have been in the clinical trials. But I think patients are still too apprehensive of it. They kind of want to go to the traditional non-hormonal pharmacological medications first,
So
which usually are SSRIs and
I was
SNRIs.
just going to ask you about that, but
Yeah.
just to finish off, I'm going to say I don't know why I cannot say this
I
word.
think it's Viusa.
Viosa. Okay. It does not do anything for longevity or health span
Yeah. Well,
that we know of.
theoretically, I guess I would say the jury's still out because it's so new. So
Okay.
in order to evaluate longevity, you need decades of research. And we have that with estrogen because we've been prescribing estrogen since we had
Okay.
Premarin, horse estrogen.
Yeah.
But we don't have that with this medication yet to know.
Okay. And then the SSRIs are simply to address the mood disturbances that often happen when your estrogens go down.
Yes, and the sleep disturbances, and which can then have, that has a snowball effect, which helps with brain fog, and that helps with, anxiety and depression. There are some data that say that SNRIs and SSRIs help with hot flashes as well, which is why they've been approved for the use of vasomotor symptoms.
Oh, interesting. So they can help with hot flashes.
Yes. Yeah.
Oh, I didn't even know that.
Yeah.
That's so interesting.
Yeah.
Okay. And so is this the route that a lot of doctors go instead of HRT?
I think when someone doesn't want, so in my experience with the OBs that I know, yes, when a woman comes and says, I have menopausal symptoms and I don't want HRT, almost, I would say 99 to 98% of the time, they're prescribed an SSRI or an SSNRI. I would say that is one of the most common things.
Okay.
Maybe, and we can get into soy, which I think is maybe where doctors go next if a woman doesn't want estrogen and doesn't want an SSRI or an SNRI. Gabapentin is also used, which is an anti-seizure medication. And oxybutynin, which is an antispasmodic agent, is used, but that's mainly used to treat like urinary symptoms. And
Okay.
Klonopin is used, and that's used to help with the sleep and the mood changes that kind of go along with sleep.
What
So
is that? Is that a sleeping pill?
yeah, it's a benzodiazepine.
Oh, okay.
Yep.
Okay.
Yeah. So those are the main pharmacological medications that are used for the treatment of menopausal symptoms.
Yeah, I've been offered, because last year I was having some issues with sleep for a period of time, and I was offered, yeah, I was offered a prescription, which I never personally, I just didn't fill it. I'm like, I'll figure this shit out myself, because I just didn't want to go on it. And that was my choice. I didn't want it. Because I know that sleeping pills, I know enough about them that it could become addictive. And I've never been offered an SSRI, but I also know that that comes with risks too, like in terms of when you want to get off of it, or if you want to get off of it, right?
Yeah, and then the issue I find, and why I really try to steer clear of SSRIs and SNRIs when prescribing for menopause. Now, you want to talk about postpartum depression, or you want to talk about depression,
Different.
anxiety, a different thing, that's a totally different topic.
Yeah.
But for menopausal symptoms specifically, is that I find that it just exacerbates the other symptoms. So now a woman, when she goes on SSRIs or SNRIs, now she has no libido. Now she has no sexual desire. Now she has a total inability to orgasm, or she has, a lot of the dry mucous membranes that's associated with menopause, the vaginal pain. So
And
sometimes
then weight gain can happen with some of them too, right?
yeah, and I just find that it's kind of like playing whack-a-mole. It's like, okay, I'm going to solve over here, but then this symptom's popping up over here. So I
Yeah.
really try to avoid that type of prescription in menopause, unless I really think that this could be a chronic untreated anxiety or depression that's been going on for decades and really wasn't treated. Or this patient was never offered or never discussed or never thought about taking these medications or was afraid of these medications. Some patients are afraid of SSRIs or SNRIs for various reasons
Right.
as well. So sometimes they just need someone to have a good old conversation with them about the risks, benefits, pros, cons.
Okay. That's good to know. Now, so those are all of the pharmaceutical options that are actually indicated for menopause, for symptoms, right?
Yes.
But
Those are
then
the, yeah.
let's get into the natural stuff, because I find, obviously, I know way more about that stuff. And phytoestrogens are a really interesting one. So let me ask you this before we get into this, because you see some women just before they hit menopause, their bleeding gets worse. Like
Yes.
heavy bleeding. And then you see others where it just kind of peters away and never comes back, and they get lighter and lighter and lighter until they're like poof, gone. And that actually happened to me, and I'm like, I love that. It just kind of, right? But then there's women who deal with the heavy bleeding and clotting, and they might have shorter cycles, like it's only 3 days, but it's awful. They become anemic. Why does this happen, Kristin?
Yeah. So that's happening because estrogen is actually the last hormone to go down in perimenopause. And the first three hormones that go down are progesterone, DHEA, and testosterone. And so as those hormones go down, especially progesterone. So progesterone, when you have a normal menstrual cycle, the normal menstrual cycle is divided into two phases: the follicular phase, which is the first half of the cycle, which is dominated by estrogen, and the luteal phase, which is the second half of the cycle, which is like day 14 to 28 in a standard 28-day, cookie cutter cycle, that's dominated by progesterone. So as progesterone starts to decrease, you have estrogen dominance. Estrogen is not decreasing yet until you get to the menopausal time. Progesterone is going down, and now you have less progesterone in that second half of the cycle. And so the cycles are getting shorter because progesterone is actually what makes that cycle go until 14 to 28 days.
Mm.
It's actually, we use progesterone a lot when we want to extend a cycle or when we want to extend a cycle for fertility purposes. I should say we use progestins, not progesterone all the time. And so a lot of times when a woman is experiencing very, very heavy cycles, supporting progesterone production through various different ways, using a precursor hormone like DHEA, or using topical progesterones, or using some of the natural remedies that we'll talk about to support progesterone, can actually help to prevent that estrogen dominance and then prevent those periods from being so heavy. And then women often get the PMS symptoms. This is when we see fibroids come up for a lot of women during this time. Again, it's estrogen dominance. We see endometriosis during this time, estrogen dominance. We see cervical polyps, we see endometrial polyps. So all of those signs are signs of estrogen dominance, and supporting with progesterone in the 40s can be very helpful to prevent these symptoms from happening. So you might have just had more of a gradual decline in your DHEA, progesterone, and testosterone, or a later decline in those hormones that coincided more with your estrogen, which is usually atypical. So most women experience those heavy irregular periods and get that estrogen dominance in their 40s. That's kind of more classic, more traditional, more typical what we see.
Yeah, but I was supporting progesterone since my 40s.
There you go. So
there you go. Like I started, and I know we're going to talk about Vitex or Chase Tree. And so that's how I started, because I had such horrible breast tenderness that, there were times that I couldn't even sleep on, like it hurt to sleep on my side. It was that bad. And so we can talk about Chase Tree and or Vitex. It's also called Vitex. But I started with that in my 40s, Kristin. And honestly, it was like life-saving until it just wasn't enough for me. Then I had to step it up, right?
Yeah, that is like really common. I think that's the most common thing that we see with women who kind of go the natural route, is that it works really, really well until it doesn't work anymore.
Yeah.
And that's very, very, very common and very, very typical. Although women who have mild menopause, mild perimenopause, sometimes non-hormonal supplements are enough because their symptoms are very, very mild. And then supporting progesterone with a topical progesterone, with yam supplements, with Vitex, with red clover can be enough to get them through the kind of changes and the estrogen dominance that tends to happen in the 40s.
Okay, you mentioned yam. That's another one.
Mm-hmm.
So that supports progesterone as well?
Yes. Yeah. Mm-hmm.
So Vitex, Chase Tree, yam. What else supports progesterone?
Red clover.
Red clover.
Mm-hmm. Yeah. And there's some theories. So that's the thing, is like now we're getting into these studies that have like 250 women and 94 women, and like much, much, much smaller sample sizes. And then also it's kind of just been what women report. So now you're kind of getting into these much, much smaller like women, it's just experiential a lot.
Yeah.
But bee pollen is another one, and maca is another one.
Yeah, but can't maca raise estrogens too?
So maca, yes, but maca really is geared more towards testosterone. And so testosterone can sometimes have a positive feedback loop for some.
Yeah.
And so that's another thing where getting into like a lot of what we do at FemGevity too, is like we do a lot of diagnostic testing and we do a lot of DNA testing. And so we're just starting to scratch the surface with what we're able to learn with DNA. I mean, it's just fascinating. And I think like every month, it's just more and more and more and more information. And so what we know now versus what we're going to know a year from now in terms of like, so then we're going to know, okay, well, based on her genetics, maca won't be good for her and she should have Vitex, or she should have red clover, or she should just go for topical progesterone, or she should go for bioidentical or commercially made.
Yes.
It's just the field of genetics is just fascinating and moving at a rapid light speed pace.
I love it. I love it because I sit there. I mean, God, I feel sorry for my family sometimes, Kristin, because I'll sit there and I'll analyze everybody's genetics and I'll be like, okay, you need this form of B instead of this form and
Right.
B12. You know what I mean? Like, don't take synthetic, whatever you do, like, and my family just looks at me like I'm insane half the time, but I go down that rabbit hole of genetics all the time because
Yeah, it's a fun
it's,
hole.
it is a fun hole. Yes. Okay. So I kind of stayed away from phytoestrogens for a while when I was in my 40s. Now, phytoestrogens, soy, flaxseed, I mean,
Yeah.
I
And
know that they support healthy estrogens. They're not going to cause cancer again. But
right.
when
Well,
you're a little estrogen dominant, like, what do you
yeah.
think? Maybe kind of
Yeah.
lay
So
off, right?
I really, like I said, I really kind of segregate perimenopause, menopause,
Yes.
postmenopause.
Yeah.
And
Yeah.
I really don't like to support with any estrogen, soy, phyto, soy protein, isoflavonoids when a woman is menstruating still. So
Yeah.
when a woman is perimenopausal, because she's making her own estrogen and she's making enough estrogen. And so, I think women get confused because like they can be in perimenopause and then they'll get a product like Bonafide or they'll get a product like Esquel and it'll have soy in it and they start taking it and they don't understand like why they're better, but then they're worse. And that's because their estrogen is up and down and up and down and up and down. And so they kind of match on the good days when their estrogen is low and it feels good, but then on the days when their estrogen is high, it feels bad. And so I have found that because progesterone and DHEA, I mean, really progesterone and pregnenolone and DHEA are precursor sex steroid hormones. When you supplement with those first, DHEA, progesterone, that supports the body, with the Vitex and the red clover, that will support the body to make the hormones that it needs. And it makes and balances the estrogen until a woman gets into the menopausal time where she has no estrogen left. And then we replace with phytoestrogens and soy products. And that works usually very, very well. And again, it works well until it doesn't work well. And it needs to be taken early. And I tell this to so many women. I tell this to all my friends and my family. And some people listen to me and some people don't. But it's really, you want to take these things before you start feeling symptoms. So if natural is the way you want to go and you want to take natural supplements, you want to start taking them based on your lab values and not your symptoms. Because once you're starting to feel symptoms, you're far down in the cascade. And so starting the phytoestrogens based on your lab values, based on a rise in FSH really is when it's a good time to start taking soy and phytoestrogens and then to increase. And you can go from like 50 milligrams, like all the way up to 150 milligrams a day of soy. And then that's going to help to level out estrogen without using any HRT. And we know that soy is safe because when we look at the studies, so there was this great study done again in JAMA, so JAMA, New England Journal of Medicine, my favorite journals. It was in 2006, and they did a meta-analysis of data system review of the difference between soy and HRT. And they did find that soy works. Not as well as estrogen, but they did find that it works. And so that's what I just want to tell women who don't want to go on HRT is just get on soy and get on soy early and don't be afraid to increase, because that's going to make it so that you don't need to go on HRT long term, in addition to liver detoxing and gut microbiome detoxing, because that's going to mean that you're going to be able to process those estrogen metabolites and you're not going to have those extreme highs, which cause the overwhelming hot flashes, anxiety, insomnia, palpitation symptoms that come along with menopause specifically.
I love that you say that. And then just to add to that, because you're using soy, which is a phytoestrogen, would that not also have the longevity benefits as well?
Yeah, so this is where I think the research on this is really kind of cool. There was a study done, I can't remember when it was done, but it found that in doses of 200 milligrams or more of soy a day, there actually was hyperplasia in like 4% of patients, there was hyperplasia of the endometrium, which means that it's working to the level that HRT is working, and could potentially have the same effects that HRT has.
What is hyperplasia?
So hyperplasia, sorry, means like an overgrowth of the endometrium.
So like a thickening a little bit?
The thickening, yeah, the thickening.
So you have a young uterus again, ladies. I'm just kidding. I'm just kidding. But
yeah, so
but it's, I mean, it's a sign of more of a youthful.
yeah, and it's a sign that it's working to the same level that estrogen would be working towards. And we have to be careful, because then we don't want to go too far and we have too much of an overgrowth and then end up with having, overgrowth of the uterine lining and then uterine cancer. But it means that it is working. And so I think that, yes, there aren't any studies, because no one's going to study soy. There isn't money to be made on soy. There isn't long-term money to be made on soy. And so the studies are going to continue to be very, very small and published in these non-discrete journals. And nobody really pays attention to them because they don't really feel like the studies have any merit. But that, yes, the phytoestrogens and soy specifically can have significant impact. So soy, I think, is like my number one go-to when someone's like, I don't want something hormonal. And I'm like, you got to get on it, and you got to get on it right now. And you got to start using it, and don't quit, and don't back down, and like keep going. Another one that we didn't mention too is black cohosh. So black cohosh has a very similar effect and works very similarly. And it's the same concept. You have to take the black cohosh regularly, and it's going to balance out those estrogen irregularities that happen during menopause.
Okay, so that's really more supporting those hormonal functions and even elevating them, like raising them, right? Because the whole problem is that they get lower, they get flat. Like women can get very flat at menopause, like flat mood, flat libido, flat everything, right? Like it's like vitality. For me, everything is always about vitality. I want to feel like I'm 25 when I'm like 85, right? Like I don't want to feel flat in everything.
Yeah, or I would even take 45 at 85, like I would take
that. Yeah, I mean, yeah, absolutely. So I think those are like the main ones to actually support estrogen and then progesterone. But then there's a lot of herbs just for symptoms. Like, I was making sage for a while for hot flashes. Didn't really work for me. It did work for somebody else that I recommended it to, a few people actually, but didn't work for me.
Yeah. So, what's interesting is that like there was one study. So, placebo effect is 30% effective. But they found that with menopausal studies, placebo effect can be as high as 50% effective. So I think that's a very interesting finding, because and I think that it's a testimony to the mind-body connection and just how important the mind-body connection can be for menopause specifically. Because if we're getting a 30 to 50% increase in a placebo effect when someone says this works for menopause, and then you believe that it does, like sage, for example, which there's no studies that really kind of prove that sage works, but that some people it worked for. And my husband always says placebo effect is still an effect. He's like, that still is absolutely a treatment that can totally work. He's like, if I had knee pain and someone gave me something and said placebo effect, but my knee pain went away, I would be like, great, give me more placebo.
I'll take it.
Yeah. So but then when we get into, it's more like about melatonin for sleep, and L-theanine for sleep, and valerian for sleep, and glutathione for energy, and omega-3 essential fatty acids, and magnesium. Magnesium can actually enhance the effects of soy and phytoestrogens and enhance the use of menopause or HRT. So sometimes women are like, just give me the baby dose of Biest, for example. So Biest is a bioidentical estrogen. Give me the baby dose of Biest. Then I'll advise them to take a magnesium glycinate to enhance the absorption, and so that they're getting the most out of the little tiny amount of estrogen that they're taking to make the estrogen more effective. So it has like a potentiating effect on the hormone itself.
Yeah, I take Biest. I love it.
Yeah, Biest is like one of our.
I've heard negative things about Biest, but I'm like, I love it. I've been on it since March. Oh, well, no, let's finish this conversation first. See, we're already past 1 hour, Kristin. Okay. I've heard curcumin for hot flashes.
Yeah, so that one doesn't there's a lot, there's like a whole list, like ginkgo biloba and yeah, turmeric and curcumin and I didn't even write them down because like
A lot.
there's so many more that there's really no evidence behind them that has any traction. So everything else that we talked about, I think like the flaxseed, the black cohosh, the red clover, the maca. Maca is also really helpful specifically for libido because it's linked to testosterone levels. The bee pollen, the soy, the omega-3 essential fatty acids, the magnesium, those are really the ones. There's also, and then if you want to get into like non-supplemental things, those are the ones that really have evidence behind them that I think is worth anything. Everything else, like, I did read about the sage and there's something about snake root and there's licorice root and
Yes, licorice. Yeah.
yeah, that none of that really had any meat behind it, like that I felt like I could say, and I don't use that. I don't use them because I don't find that I need to go that far into my well. Like after I go through, okay, we don't want pharma, we don't want bioidenticals, the soy isn't working, the bee pollen isn't working, the combination of supplements and gut microbiome balancing and liver detoxification isn't working. I don't really find that I'm now into the sage and the licorice root. I don't go that far down into the toolbox usually.
Okay. I think we kind of covered everything, but I do want to ask you this.
So there's a few other things
Oh,
too.
okay.
Yes. So there is a wearable called the Ember 2 Wave. And I don't know if you've heard about this device.
No.
It kind of looks like an Apple Watch. It works with the process of something called interception. So interception is basically it's a symptom response. It's like a symptom responder to how we gauge temperature, and we have a lot of receptors on our wrist for this. And I don't know if you've ever experienced this, but do you ever like run your wrists under cold water or hot water to like warm you up or cool you down?
Never.
So it can work pretty well. If you're ever like hot and you just run your wrist under cold water, it can cool you down. And so that's how this technology works. It's a cooling device that you wear on your wrist. Yeah. And so
Really
it's pretty
interesting.
effective. And it works pretty well. So and it actually beats the placebo effect. And it's great because women sometimes will get like the prodromal hot flash symptoms. They'll know it's coming on, and then they can just touch this device and it will help to kind of calm their skin down by cooling their wrist, and it gives them a sensation of feeling cool.
So cool. I've never ever heard of that.
Yeah, it's called the Wave 2, and it's by a company called Ember Labs.
Very
So
cool.
I think they're not cheap. I think they run about $300 or so, but they sell them, I think, like Walmart and Amazon and everywhere like that. Yeah. And then there's been a lot of studies about like cognitive behavioral therapy techniques, which again would point to the 50% placebo effect, or exercise, yoga, mindfulness, relaxation, and cannabis. Using marijuana for menopause.
Is that legal in New York?
Yeah, it is.
Yeah, it's legal here too in Ontario. I think in all of Canada. I don't even know. I know it is in Ontario. But I know that, and this is just from experience, and of course, we're not suggesting anything illegal, so check and see if it's legal wherever you are, if you're listening. But having CBD with just a touch of THC, like I'm talking a little bit, because
like
it's
a homeopathic dose.
Yeah, it's like you don't get high, but it's like a full spectrum of the plant, right? Can be super effective to go to sleep and stay asleep. For those of you who have these issues, I know I've tried it, and it definitely works for me anyway.
Yeah, and so that's and again with DNA testing, you can find out, are you a cannabis responder or not? Are you an upregulator or a downregulator? So you know,
Yeah.
or people do trial and error. That's the old-fashioned way. Like try it, see if it works. If it doesn't, then you know.
Yeah. Well, I
Yeah, but I
will
think that
say,
was those are the main things that I think we use, and those are the tools in our toolbox.
yeah, what I just want to finish on that. One thing I will say is my husband, when he takes it, he'll have a recovery of like 97% and his HRV will be through the roof. So, check it out. And if you're like a metrics person and you measure, like just see if it works. Anyway, stress, one more thing, stress. A lot of the things that we talked about also help with stress, right, Kristen? Because
Yeah.
stress is a big thing. And I don't know if you've ever heard this, but I've used this almost as an analogy. It's like, women, I think it's such an important conversation because women enter a different phase of their life when they're going through menopause. Many are taking care of elderly parents. Many have kids that have left the home or who are kind of half in, half out. Many are trying to figure out what are they going to do with the rest of their lives. Many are trying to retire. Like, I mean, many have financial issues because they're like, oh my God, how am I going to retire? There's a lot of stress at this stage in our life. So it's really important to support it however you choose. Because we've named so many different things. And one thing, have you ever heard this? Like I've always said stress is like, think of it as like almost like Pac-Man eating up your progesterone, which is the hormone that makes us chill, and it's the hormone that makes us sleep, right? So we kind of need to address the stress. Address the stress. Do you agree with
Yeah.
that?
Yeah, I think that, I mean, cortisol is so far down in the sex steroid cascade. So when that's not working, it's throwing off the whole, it's throwing off the whole system. And it's it's like you can't get your TV to work, you know, it's like that on
Yeah.
your TV, or the you know, you like not being able to use your computer, like you need a total reset. And the only way, I mean, you probably know better than me, because I'm always amazed at how much nutritionists know. They're like probably the doctors that everybody should go to first. Um, but the like it's just amazing that there's not really a lot to do for stress other than stress reducing activities. Like there's no pill, there's no magic like diet, or there's nothing that you can ingest. It's a lifestyle and mindset change that has to happen in order for stress to reduce.
Yeah. And there's a lot of tools too, right? Like I'm sure you know about ashwagandha and rhodiola. I always say ashwagandha is more of that stress and wired, rhodiola, stressed and tired. Most of us women, we have both. So I'm like, just take both.
Yeah.
Take both.
Yeah.
Unless you have some sort of aversion to it. But I'm like, I feel we can't take away stress, but we can change our response to it,
Yes. Yes. Yeah. Yeah.
right? Like, this past weekend, my son's car was broken into, golf clubs stolen. It's like the long weekend, Labor Day. You can't, like, I mean, I had to get the car towed. I'm like, stress, but hey, stuff happens. It's just how are you going to respond? Are you going to freak out? Or are you going to go, oh, thank God you weren't hurt? So
Right.
all's good. All is well, right?
Yes. Yeah.
Yeah. So tell us, where can we find you, Kristen?
Yeah, so we are at femgevityhealth.com, and we're on all socials, just at FemGevity. So on Instagram and YouTube and TikTok and Facebook at FemGevity. And we respond pretty well to our DMs. You can email us at hello@femgevityhealth.com, and we're happy to answer any emails. We also do a IG live. So if you follow us on Instagram, we do an IG live every Monday night at 8:30 Eastern time. So people can come and ask questions, and we can elaborate on anything that we've talked about today. We're happy to do that.
That's amazing. Thank you so much. This has been such a great conversation, Kristen. Thank you.
Thank you for asking the great questions.
Thanks. Okay, I hit stop on the audio. Hold on. Stop.